What are the clinical considerations when performing amniocentesis or chorionic villus sampling for multiple pregnancy? It is recommended that in the case of multiple pregnancies, a chorionic villus sampling or amniocentesis is performed by a specialist who has the expertise to subsequently perform a selective termination of pregnancy if required. A high level of expertise in ultrasound scanning is essential for operators undertaking amniocentesis or chorionic villus sampling in multiple dichorionic pregnancies because uterine contents have to be mapped with great care. This is essential to ensure that separate samples are taken for each fetus and clearly labeled as such. Labeling is greatly assisted by the presence of obvious fetal abnormality, such as hydrocephalus or heart defect, or discordant fetal gender. However, to minimize the risk of chromosomal abnormality being assigned to the wrong twin, invasive procedures in multiple pregnancy should only be performed by a specialist who is able to proceed to selective termination of pregnancy. It is very unlikely that a specialist would be prepared to carry out a selective termination of pregnancy relying on information provided by a referring doctor, particularly in the absence of clearly identifiable ultrasound appearances. The role of chorionic villus sampling in dichorionic placentas remain controversial because of a relatively high risk of cross-contamination of chorionic tissue, which may lead to false positive or false negative results. This risk may be minimized if two separate needles are used. Such procedure should be performed only after detailed counseling. What information should women be given about third trimester amniocentesis? Women should be informed that third trimester amniocentesis does not appear to be associated with a significant risk of emergency delivery. Women should be informed that compared with mid-trimester procedures, complications including multiple attempts and blood stain fluid are more common in third trimester procedures. Amniocentesis in the third trimester is carried out for a number of indications, most commonly for late karyotyping and detection of suspected fetal infection in pre-labor preterm rupture of the membranes. When amniocentesis is carried out in the presence of pre-labor preterm rupture of the membranes, failure rates are higher. Serious complications are rare. There is a suggestion that culture failure rates may be higher following third trimester amniocentesis with a rate of 9.7%. What are the risks of transmission of infection? The ultrasound probe should be enclosed in a sterile bag during any invasive prenatal procedure unless suitably audited processes for probe decontamination and gel microbiological surveillance are in place. Separate sterile gel should be used. Invasive prenatal procedures should not be carried out without reviewing available bloodborne virus screening tests. Where women decline screening for bloodborne viruses and are being counseled for prenatal diagnostic procedures, inform and document the potential risk of vertical transmission of infection to the fetus. Review viral load and treatment regimens prior to invasive prenatal testing in women with HIV and consider delaying the procedure until there is no detectable viral load if the woman is already on treatment. Consider antiretroviral therapy prior to prenatal invasive procedures in women not yet on treatment for HIV. Invasive prenatal testing in the first or second trimester can be carried out in women who carry hepatitis B or C. The limitations of the available data should be explained. Severe sepsis, including maternal death, has been reported following invasive prenatal procedures. The level of risk cannot be quantified as case report literature does not provide denominator information, but the risk of severe sepsis is likely to be less than 1 over 1,000 procedures. Infection can be caused by inadvertent puncture of the bowel, skin contaminants, or organism present on the ultrasound probe or gel. Ultrasound gel may contain organisms, and many departments have mechanisms to minimize the risk, including the use of a sterile ultrasound gel when performing invasive procedures. Standards for control of infection should conform to those for any invasive diagnostic radiological procedure and are commented on by the Healthcare Commission. Blood-borne viruses constitute both an infection control risk and a possible risk factor for maternal-fetal transmission. The risk of a transmission of hepatitis B was very low. It has been suggested that e-antigen status may be important, and recent evidence shows that the maternal viral load is more important for determining the risk of transmission. There are fewer data on transmission of hepatitis C, but no evidence that transmission is increased following amniocentesis. Most studies examining HIV suggest that invasive testing may be a risk factor in transmission to the fetus and recommend avoidance. The data are most robust for third trimester procedures where the relative risk is poor. Whenever possible, procedures should be delayed until treatment has optimized the maternal viral load. If no HIV test result is available, advise delaying the invasive test and perform a rapid HIV test. If results indicate maternal infection, then the risk of transmission should be discussed and consideration given to starting antiretroviral therapy to reduce the viral load prior to the procedure. Rhesus status. Maternal RHD status should be available or obtained in every case. Prophylaxis with anti-D immunoglobulin must be offered following each procedure in line with national recommendations. How should care be organized in providing amniocentesis and chorionic villus sampling? Women facing either procedure are usually anxious, and clinicians should bear this in mind. Hospital trust and organization should ensure that the equipment, environment, staff training, arrangements for follow-up, and links with related service carrying out pregnancy termination or support for women with diagnosed chromosomal or genetic disease are of sufficient standard.